an experience I had with a family in an ICU with a family member who was dying. And they didn't agree on whether or not to remove life support. The way I was able to intervene and sort of mitigate that situation and bring everybody to some calm about the situation, I would like to see a bot do that. It's just one example of why you still sometimes need humans in the mix. We're so proud of our portals and look at all the functionality in the portal. The portals are actually mostly for us, not for the people we're serving. They find it cumbersome, challenging, and frustrated by keeping up with passwords. And so once they've navigated and they figured out which button do I click to see my test results, I'm good. And maybe appointments. So we've quizzed a lot of people about this. People do not go into their health portals for health information. And we're spending like hundreds of millions of dollars populating these things with health information nobody ever looks at. Let's meet people where they are. A lot of people, I'm going to get a lot of flack for that one because they think it's so represents what we should be doing. Maybe it does, but that's not what we're doing. There's another mantra I hate in healthcare, and that is we have to bridge the digital divide. Over 92% of people have a smartphone. That's not the innovation we're creating. We're not creating innovations for people living in poverty who have smartphones. We're creating things like Oura rings and fancier Garmin watches and Fitbits so that people can, track their own health data. But aren't there more simpler innovations we could create to help bring people along who already have a technology? Or do we just want to say, oh, they don't have broadband in their house, so we can't innovate for them? If you run a health system, there are people working throughout your organization who can give you this feedback and intelligence. Passing trays, food service, environmental services, transport people. These are your eyes and ears. Not to mention a lot of them have a lot of similar challenges, and you can ask them for their feedback and input, but we never do that. Instead, we'd rather get a consultant to come from the outside and give us advice that people who probably work in food services and environmental services could have already told them. Trust is measurable. We just have to decide we're going to measure it. Because a lot of people say, oh, trust, it's so squishy. Like, what do you do with that? Medication non-adherence, emergency room visits when you have a PCP, clinic no-show rates. These are all measures of trust.
You've said that health literacy is more than reading levels. It's the trust, it's the fear, it's even body language. What's something that you've seen on the street recently that surprised you?
These days, it's hard for me to be surprised by what I'm hearing and seeing because I had those shocking moments like starting years ago. But still, the things that are relevant are how much people distrust healthcare providers because they think we are, and this is one of the most prevalent things I hear, meaning almost every time I'm out, I hear it in some fashion. People are distrustful of doctors and healthcare systems because they think we are collaborating with drug companies to make money. And that all we care about is pushing pills. And some people even believe the pills are making them sick. So there's a lot of health literacy linked to people's willingness to engage and their trust in the healthcare system. And I think we're not giving it the time and attention it deserves. And we have to have some humility about this. And we have some growth to do in this area.
What is one phrase in healthcare that you wish we would retire?
Meeting people where they are.
Really?
I think we say that all the time, but we don't do it. It's easy to say. And I think we intuitively understand that healthcare has to be tailored. Healthcare has to be humanistic. Healthcare has to be fashioned in a way that that it fits into the person's life and their needs, wants, desires. It's easy for us to say that. But we get a lot of, meaning we the healthcare system, we get a lot of feedback about what we're doing wrong in healthcare. But it's not being addressed despite hearing all of these things. So when we say we meet people where they are, to me, it's just a cliche.
Is it possible that we sort of put this overrated emphasis on patient engagement in terms of like systems are so obsessed with engagement metrics, but they don't actually want that feedback?
I think so. And I've actually had Healthcare leaders tell me this. They say things like, if we get the information, then we're accountable for acting on it. Or what am I going to do with that information if I get it? So they'd rather just not ask the questions, sadly.
Do you see that performative engagement hurt outcomes?
Well, I think we have to ensure we understand and we accept the connection between trust, health literacy, and engagement and outcomes. So, a good example is this gentleman who told me on this, who accused me of being a drug dealer. He didn't know me. He knew I was a doctor. I had on my white coat. And that's basically what he said. Well, why should I listen to you all? You are nothing but drug dealers. So we had this conversation. I didn't get defensive. I really wanted to understand where he was coming from. And he said he'd have to be dead or dying before he went to see a doctor, because he would end up dead anyway, because all they want to do is make money. So if these are the perceptions out in the community, and this is not just in the Black community, like I hear this from all sorts of people who believe that healthcare is a money grab. And let's be honest, healthcare is a business, right? So whether we mean well inside the healthcare system, it's about the optics on the outside. And if we are not humble about receiving that information and trying to respond to it, people will never trust us. So if they don't trust us, they will delay care. They will use the emergency room because it is easy, it's there, it's open 24/7, most of the time with non-judgmental care, no questions asked. And they'll delay their care until it becomes dire and more expensive. So if you peel the onion on why we're spending a lot of money in this area, treating preventable diseases, preventable hospitalizations, avoidable ED care, a lot of it is linked to trust. And a lot of that trust is linked to how much people understand about their body, about healthcare, about what questions they should be asking. Why are they taking these medicines? What's the purpose? All of these things fall under the umbrella of health literacy. But I think when you say health literacy, it sounds a bit wonky, a bit academic. Some people don't like the term. But ultimately, it means, are we effectively communicating with people in a way that builds trust so that they can better engage in healthcare? So I see this very clearly, very plainly, but sometimes a hard message to resonate across the healthcare system.
What should patient education never be like?
Talking heads and wonky written documents. So, all one pagers are not created equal. Some of them are written in plain language with a bit of relatability and humor, but nowadays people don't like to read documents. So I would say those two. Having a talking head person, it's like the Charlie Brown teacher, wah, wah, wah. Like that's how people perceive that kind of education. And then the one pagers, which are populating most of our electronic health records and the case management databases. I think we have to ask ourselves, who's benefiting from the status quo when it comes to health information?
Have you seen any examples of any pilots or any organizations that maybe got really great metrics, but totally missed the point for the people it was meant to help?
Well, I think this happens a lot, but I also think we don't have great systems for evaluating what we buy and what we do in healthcare. And I understand the importance of quality measures and why they're there. But first of all, we have too many quality measures. And the question is, does every entity need to have the same quality measures? It depends on your goals and what you're trying to do. But ultimately, if we can't figure out how to evaluate the things we're spending money on, I think we'll continue down this road, spiraling toward escalating healthcare costs with the same or worse outcomes than we have now. So I think there are examples of that, but I think there are many more examples of the opposite.
You've said that you've even had patients who have called you a home health aide, or that thought that you were a home health aide. I think that was that was the post that actually led me to you in the first place, because it was just so good. But you said it was a good thing. What's something else systems think is a bug or has like an unintended effect, but is actually a feature?
Oh, that's a good question. But I think anything that brings humanism, relatability, bridges the gap or the social distance between healthcare and people could potentially be a great bug. But we have to be intentional about building those things into the system. So yesterday, someone was telling me, I was telling him about a case that's very similar to the one you're bringing up. You're talking about the woman who heard about me on the street, and someone gave her my phone number. And she sent me a text message and said, I heard you're the case manager or home health aide or something, she called me. Could you help me understand my diabetes? So I was explaining this example to a healthcare administrator, trying to make a case that we need to have better interventions for health literacy to build trust and improve engagement. The response was, well, that's what doctors are supposed to do. That's what their primary care provider is there for. And theoretically, we all know that's true. But primary care providers do not have the time. They're under too much pressure to deliver that sort of hand-to-hand education and support for a person. And so someone else might say, well, that's what case managers do. And it's true, but we have to equip case managers, community health workers, all sorts of navigators. We have to equip them with the right information so they can be that bridge. Because I think too often we say, oh, you can be a community health worker because you come from the same zip code, you have the same skin color, the same background. But then we don't take it a step further to give them the tools they need to be able to assist this woman in the way I was able to, because I had some clinical insight and some information about how she should be thinking about food and nutrition. So I think we have the pieces within healthcare. It's just not, we haven't integrated them in the right way to be able to help people the way they need to be helped.
Definitely. And I'm so glad that you shared this story for the listeners, because I think it's a great one. If you were designing an onboarding flow for a new patient with Medicaid and diabetes, what's the first thing that they should see, feel?
Well, I've actually done this. So it's interesting how we stovepipe each other in healthcare. And because this is what you see me doing now, like everyone sort of stamped my forehead with health equity. But actually, before that, I was a healthcare administrator. I was an academic researcher. So I've done lots of different things. And so in one of my roles, we established an outpatient clinical center. And we were very intentional about what kind of environment we wanted for patients. And we all learned this from our own experiences. We talked about it. And so the first thing, when you walk in the door, it needs to be welcoming. Someone needs to smile at you and greet you. And this sounds very simplistic, but guess what? It's not happening in clinics and health systems all around the country. Because this is one of the concerns we hear, where people are rude to me, or they look down on me, or when they see I have Medicaid, they're so rude, I never want to go back. So we wanted to make sure no matter who was coming in the door, that they were greeted by a human with compassion and someone who is genuinely happy to see them. And it takes some intentionality, and you have to cultivate that kind of environment. You have to hire for that. The second thing is, when we put the forms together, what kind of information are we asking? There's all the typical information you have to ask, but we also asked about unusual things like, if we can't get a hold of you at this number, tell us the next two people who will know how to get a hold of you. Like, what's their phone number? We also wanted to know, how do you learn best? Do you want to read something? Do you want someone to tell you? Are you a visual person? And we forget about these things, because when we're in the room talking to someone and we don't know their learning preferences, we miss an opportunity to make sure we're communicating with them in the way they need the communication. So those are the two big things that come to mind, but we tried to be very intentional throughout the way we develop the services and the formats and what's the word I'm looking for? Protocols for that clinic.
I'm so glad that you brought up your background, because I think your transformation is just so amazing. So please tell your story, but from what I've seen, we take it back to the A, where you start in, a little office called the CDC as an epidemic intelligence service officer. And so when you started as that data-driven scientist, did living and working near these most underserved patients sort of shape how you saw that disconnect, and how you now see that disconnect in language and trust and culture and that kind of thing, especially when they create preventable health disasters?
Absolutely. So even before I went to CDC, I was always a curious person who was also very interested in other people, relationships, talking to people. My father was like this, or is like this. He's someone who's never met a stranger. So growing up, I was also very outgoing and interested in talking to other people. But when I got to CDC and was thrown into field investigations, I learned that people don't really understand what we do or why it's important to them. And fast forward to today, we see that right now. A lot of the questions people are raising about the value of science, public health, why there needs to be infrastructure for these things. I saw that way back in 98 when I started at CDC. So we would go out in the communities to do field investigations, and we'd have to talk to people. And the kinds of questions we would get were very basic. People didn't know what CDC was. They didn't know what public health is. And we did some investigations around HIV. And as you can imagine, there are a lot of myths and misinformation about what HIV is and how it's transmitted. So that really opened my eyes to the need to really understand, like, where are people coming from? Where are they getting confusing information? And one day someone said to me, I heard HIV turns into herpes. And I paused for a minute and I said, well, where'd you hear that? She says, I heard it somewhere on the bus. Someone was talking about that. Is that true? And it turns out there is an association between whether or not someone actually gets HIV and whether or not they have a sexually transmitted infection like herpes, because it causes breaks in the skin, which allows HIV to get in. And so somehow through this, this transmission of the information, she became confused. And so that was just one example of so many, how people, they need a helper to help them translate this information. And so from my time on at CDC forward until now, I've been very attuned to that, listening to where the confusion is, how the message is getting garbled, and trying to figure out how we can better communicate so that people get the information they need.
So have you seen that when people build trust in the system, they tend to act sooner?
Absolutely. But, I think the problem is all health systems and all clinics are not created equal. So we can find someone, clear up a misinformation, and then send them on their way to a clinic or someplace to receive care. And if that experience doesn't meet their expectations, we've helped set for them by explaining that's what this is what's supposed to happen now. And if there's a mismatch, that further erodes trust. And so this is what happens in healthcare a lot. I have an example of this. So when I was running this clinic I told you about, we also set up a system that allowed people to be diagnosed in the emergency department, and someone from our clinic would go down, get them, bring them right to the clinic so that we could start explaining and helping them and sort of demystifying their health condition right then, so that they would feel cared for and felt like they had a trusted resource. So one day there's a gentleman who leaves the emergency department, refuses to come to the clinic. And so 3 different people on my team try to call him, and he refuses to come in. So finally they come to me and they say, Dr. Fitz, can you call him? So I called him and I told him I was a doctor. I was like, I'm the head of this clinic. Like, we're here to help you. Like, how can I help? And he didn't want to come in. And I said, where are you? Where are you right now? I'm going to come to you. And luckily, I didn't have any patients that day. So I got in the car and I went to where he was on the street. And I explained everything to him right there out in the community. And he walked in the next day. But when he walked in, he got this certain level of care that was very human-centered and personalized. What if I had gone to him on the street, explained all this to him, and then sent him elsewhere to an experience I have no idea? Was someone going to be rude to him? Would he have to wait 2 hours to be seen or an hour to be seen? What would that experience be like? So I think the challenge is we can't control everything that happens in the healthcare system, but it is definitely linked to what information are you getting? Does it make sense to you? Do you trust it? And can you act upon it in such a way to improve your health? Like, no one can do everything. This is why we need collaborations and partnerships. We have to work together. But there, again, I keep using this word humility. There has to be an humility to help in healthcare so that we recognize when we're falling down. It's not that we do everything wrong. We don't. We do a lot of things right. But sometimes it only takes that one thing to discourage someone or send them running in the other direction so that they never come back. And I think that happens a lot in healthcare.
And the opposite can be true too, right? Because you've seen patients ignore advice for 10 years and then make that one small change. What flips that switch and finally makes the message land?
Yeah, I think there's no silver bullet. I think if you hear it at the right time, in the right way, delivered by the right messenger when you need to hear it, there's no silver bullet for everything. And some people have to hear a message multiple times before they get it in different ways. And this is why I think understanding how people learn is also really important. Because in healthcare, we give people all sorts of documents, or we send them, go to our website. You can find that on our website, or here's a pamphlet or a handout when you're leaving the emergency department, which usually ends up on the ground or in the car or stuck in the purse and someone forgets about it. But if you know that they learn by visuals, why not send them to a video or give them a video or even show them a video before they leave? So there are a lot of jobs to be done in healthcare and clinical care to help people. And I think we're so overwhelmed with some of the administrative and regulatory tasks and boxes we have to check. We don't always have the time to be creative and thoughtful and figure out, okay, what would make this a better experience for a patient? And we need more of that.
So one of the things that you have built is the health text for those populations that most digital tools ignore. So is there something that health techs get right about patient engagement that some of these billion-dollar platforms still don't?
Well, the reason we built health text is because most people are texting now. That's how they communicate. That's how they receive information. That's how they send information. And the healthcare system has been woefully behind because up until very recently, I think even last week or the week before, there was a lot of confusion about whether or not you could actually send someone a text message without getting their permission. And so I think we are now moving in this direction because of the work requirements that will be implemented soon. I think CMS and other organizations have realized we really need to better communicate with people. And so now they're creating some allowances and some flexibility around texting. But we've known that for a long time. Everyone else is texting people. And there are guardrails, there should be, because you don't want to spam people. But when it comes to their health, and if they say, I'm okay with you texting me, there should be no barrier there. So what we've learned is just a reinforcement of something we already knew, is that people prefer to get information via text. They just don't want to be overwhelmed by it. And you need to be texting them something that's of value to them. We built health text to support insurance companies, payers, mostly Medicaid payers, to better engage, but we've had a really hard time breaking through some of those trust barriers and regulatory barriers or perceptions from risk managers and compliance officers about texting. Even though they're relaxing some of the requirements, I think it's still going to be difficult because the text messages, a lot of them will come just in a blast. Like thousands of people get the exact same message in the same way. And we have learned from testing health texts, the messages need to be tailored a bit. They need to be, you can't send the same message to every Medicaid beneficiary or Medicare beneficiary. So yeah, it's been quite a learning experience with that.
How do you determine what is of value to the patient?
We do a lot of qualitative research. We're talking directly to people. As you might imagine, we're not afraid to find people and work with their trusted partners to have conversations and ask hard questions like, well, you went to the emergency room even though you have a primary care provider. Like, what was that about? Tell me about that. Like, why'd you do that? And we get a lot of insights. Where are you getting trusted health information? Like, why are you going to your grandmother instead of calling your primary care doctor or sending a message in your portal? And don't get me started on how much people do not like logging into portals. Like, we're so proud of our portals and look at all the functionality in the portal. The portals are actually mostly for us not for the people we're serving, not for patients and for beneficiaries. They find it cumbersome, challenging, and frustrated by keeping up with passwords. I mean, we hear all of this qualitative feedback coming about why people do or don't engage in certain parts of the healthcare. And so we've gotten an earful about these portals and why people don't log in. It's inconvenient, honestly.
I think that's the first time that somebody on my podcast has sort of named that truth, because I've seen it too, about sometimes our own EHR is a barrier.
Yeah, and it's hard to navigate. So I think a lot of people go there with intention to find their test results. And so once they've navigated and they figured out which button do I click to see my test results, I'm good. And maybe appointments. I think those are probably the two big areas. But health information, oh, we've quizzed a lot of people about this. People do not go into their health portals for health information. And we're spending like hundreds of millions of dollars populating these things with health information nobody ever looks at.
So it's almost like the farther away that you really are operating from the community is sort of the worse your assumptions.
And it would be okay if we are seeking the feedback and the input. If there are people at the decision-making tables who really understand and are connected to this information, people's voices, people's concerns. But often that's not the case. It's not the case in boardrooms. It's not the case in a lot of C-suites. And I was also offering a suggestion to a health leader last week that if you run a health system or you run any kind of organization, especially a big organization like a hospital, there are people working throughout your organization who can give you this feedback and intelligence. These are the people who are passing trays, food service, environmental services, people who are keeping your hospital clean, the transport people. These are your eyes and ears. Not to mention, a lot of them have a lot of similar challenges, and you can ask them for their feedback and input, but we never do that. So we don't have a lot of excuses, but we don't. And I'm using the proverbial we, as health systems and the way we operate, because I've worked in them. And I know that this is not top of mind when it comes to trying to understand how we can better serve and provide care for people by asking our own people. Instead, we'd rather get a consultant to come from the outside and give us advice that people who probably work in food services and environmental services could have already told them.
What is one belief about patients that health systems still refuse to let go of, but categorically is false in your lived experience?
That the data is too complicated and confusing for people to understand it. I think it feeds into this narrative that we have to be protective, and put up the HIPAA guardrails to help and support people, because we don't really want to give them ownership and the say-so for how we use their data. And I don't think we talk enough about that either.
Yeah, does more data automatically translate to equity and better usage and all of the things that we want to see?
Absolutely not. I mean, I wrote about this when we got on the world got on the health equity bandwagon in 2020. And I soon after wrote on my Forbes column about this, that everyone's turning to data first when we have a wealth of data that can inform us already. But I think turning to the data was sort of an easy way for people to get their heads around, okay, how do we grapple with this huge topic of health equity? First, let's get on the same page. Let's make sure we get the data. The data are not great. The data are never going to be perfect. But we have a ton of information in health records, and people say, oh, we can't access it. Well, it's because we're trying to access it in a standardized way. So, I mean, I could go on talking about, the challenges with how we view and use data. But the point I'm making is, even in my one clinic, we were able to look at the patient population and say, here's what we know about this population, the demographics, the clinical issues, the social issues. And that's just in one clinic. But it was enough to give us insight to know, okay, what should be the next step? And then maybe we could move that up, to the next level of the health system to say, is there something here that we could standardize across a set of clinics? So instead of saying, oh, everyone needs to be on the same sheet of music, but we have to fix the data first. Like, we'll never get anywhere if that continues to be our approach.
Is there a moment where human context beat cold data?
Well, absolutely. You have to have the context to understand your data. And this is why I love combining quantitative and qualitative data. Because if all you have are numbers, the numbers give me this picture, but then you look at the population or the people you're serving and it doesn't match. Like, which one do you believe? And this would come up for me a lot when I was teaching medical students and residents, because before rounds, they would always go and look at the labs. And I told them, if you're running out of time to come to rounds and you're choosing between seeing your patient and looking at the labs, I will always want you to go look at the patient, because the labs can look one way, but you get so much more context and information by looking at the patient. And so I think you always have to, even if people who are pulling information off their portals, I have people calling and saying, what does this mean? It's not exactly in the range. Like, is that terrible? It's all about what's in front of you. What does this mean? What do these numbers mean in real life? So, yeah, very important, but also I think too much neglected, especially in training.
You've said that storytelling and text messaging and proximity is infrastructure far beyond outreach. And that's a really powerful reframing. How can healthcare executives adopt this mindset?
They have to be willing. I think they have to recognize we don't have all the information at our fingertips. Or if maybe we have data that we're not using, how do we come up with a system to identify all the data we have, whether that's qualitative data, what is someone saying, what was someone's experience like, versus look at what my spreadsheet showed me this month. How do you put these things together in a way that you have a whole picture of what's going on so that you can develop a better strategy? So I think in order to get there, there has to be a willingness and awareness to take the time to do this and bring others into the conversation. Because if you're just looking at spreadsheets and data and numbers and trying to, please shareholders and board members, you'll never get the complete picture.
So if some of the tools that we've already put in place, like those EHRs, like the My Chart, if it's not working for Medicaid patients, do we kill the tools or do we rewire the system around them?
I think the tools can be very useful. I think that there's a lot of utility in electronic health records. I wouldn't want to go back to writing in paper charts. Like, that was a pain. And now with AI, I think there are a lot of efficiencies achieving with artificial intelligence, but it's a combination. It's always going to be a combination. Like, you probably have seen these conversations on LinkedIn about, AI is going to take over for healthcare providers. We're teaching AI to be humanistic. It can intuit, it can emote. It will never be a human, ever. And so once we decide that's true and figure out how you have the best of both worlds to achieve better outcomes for people, like, we'll be better off. Like, let's stop having this conversation about, is AI going to take over everything? It cannot. It will never be human.
Absolutely. I think even just in my own experience, 10 years on the front lines as a medical social worker, I can't tell you the number of times I've met patients who will check off the same box 100 times until they actually are face-to-face in a non-judgmental space. And the real story comes out. And that's something that can only be, that can only happen when that trust is built. And it's hard won. And I know you know that.
I also think a lot of the tools, we think we can program them to ask the right questions. But what's missing here is body language and all the nonverbal communication you pick up on when you're not a bot. And that is very much informing, like, the next question I'm going to ask, the decision I'm going to make about what we do next. And so I want to find a way to get all of these tech people and the people obsessed with AI to value what we as humans know, and those of us who've developed an intuition around healthcare delivery over all these years. It needs to be married with what they're doing, because they can try and give emotions and intuition to a bot, but it's never gonna work. And hope someone is doing a study on this, just asking people and putting them, through some simulations to see if a bot could ever completely replace a human. I think it does a good job with some of the behavioral health chats. I've actually been blown away trying some of those just myself to play around and see, what is the utility or the power of this. But when it comes to diagnostics and caring for people, especially people with complex medical needs, which are the most costly people we have to deal with, I think that there's a lot we have to learn there.
I completely agree. I've run these experiments just on my own, just to see, and I was really relieved when my ChatGPT tried to 302 me.
You know, and I was thinking recently about an experience I had with a family in an ICU with a family member who was dying. And they didn't agree on whether or not to remove life support for the family. And I was just thinking to myself, I mean, the way I was able to intervene and sort of mitigate that situation and bring everybody to some, calm about the situation, I would like to see a bot do that. It's just one example of why you still sometimes need humans in the mix. Like how is a bot going to, is someone going to go to a chatbot when their loved one is dying and you have a decision about removing life support? Are they going to go to a bot? Like these are real human costly decisions.
Right. Because a bot can't feel and process and hold space or empathize. Even though ChatGPT does a pretty good job at mimicking the empathetic responses, I've seen that. But I think that's another thing that I think is oversimplified when we think about these tools, is that that you cannot think or intellectualize your way out of very difficult emotions. No matter how even smart you are, no matter what your background is, sometimes you just got to feel it.
Yeah. I mean, again, I think the tools are incredible. And I see how fast and, how rapidly they're improving, even in this area of being emotive. There just has to be balance.
Well, Grapevine, from what I saw, it built health text only after these listening tours and co-design with the users. So you kind of saw it in your own experience, just through building this system, how some of these apps and portals can be inherently inclusive.
Yes, but they still have to be told what to do. They have to be fed the intelligence. But yeah, I think it has to start with the human condition, understanding what people need and want, and then taking that information and using it to build the tool.
It's kind of the opposite of the Silicon Valley logic, which is typical to build fast and then optimize it later.
Yeah, it's interesting and I've had so many rants on LinkedIn over the years. I've had one about this as well, how healthcare is so different. We can't go fast and break things. There are a lot of things we can go fast and break in healthcare, like the way we treat people, the way we build trust. I mean, they may be, it's not a tech tool, but even technology. It's about, if you build a technology or you build a better EHR, you can go fast if you decide to train people and get everybody on board with using it. And maybe that's improving workflow, which ultimately trickles down to a better experience for the patient. So I hate these mantras we use and just take them as gospel, like let's meet people where they are. A lot of people, I'm going to get a lot of flack for that one because I know people love that because they think it's so represents what we should be doing. Maybe it does, but that's not what we're doing. There's another mantra I hate in healthcare, and that is we have to bridge the digital divide. So the thing about the digital divide from my perspective is it depends on what divide you're talking about, because according to Pew Research, over 92% of people have a smartphone. That's not the innovation we're creating. We're not creating innovations for people living in poverty who have smartphones. We're creating things like Oura rings and, fancier Garmin watches and Fitbits so that people can, track their own health data. But aren't there more simpler innovations we could create to help bring people along who already have a technology? Or do we just want to say, they don't have broadband in their house, so we can't innovate for them?
And what do you think, like as a clinician over time, what do you think that does when we are implementing wearables out in the community? And so then we get data back about, and we create workflows based on these clinical trials that were only done for people who have Aura rings and have Wi-Fi in their house.
Yeah, I hate to use the word fringe, but I think people who, and I have a Fitbit, which I rarely use, but I think those people are going to be fine. Those are not the people with multiple chronic conditions, with repeat hospitalizations, who need case management for all of their health conditions. Like, that is a completely different set of people than folks who are going out and buying these gadgets and monitoring their own health. And I think we don't talk enough about, like, there's a divide there. There is definitely a divide there. And so when you look at rates of chronic diseases, the highest rates of chronic diseases are going to be in our underserved, impoverished communities, because they have least access to the food they need to be eating, means and access to cook the food or understand what to do, how to tailor food to the health condition they have. Whereas someone who's going out and buying these gadgets, they could probably, some of them can hire a chef, or they cook at home, or they have the luxury of time to be able to do those things. And it's just, these are the things we don't really want to talk about when it comes to healthcare.
Definitely.
It's not even. And it's not to say everyone should have access to the same things, but shouldn't everyone at least have baseline access to be healthy, to get good food, to be able to sleep at night, to earn a living wage? Like, these are all things influencing our health that are just hard to disentangle from health outcomes.
Do you think that scaling kills effectiveness of a program?
No, absolutely not. I think many of the things we do need to be scaled. I think it's hard to get organizations to work together. Like, to me, what comes to mind here is health philanthropy. A lot of well-meaning people, really, some doing some really great work. But what if they all work together and pool their resources, their knowledge and their resources? Like, how much further along would we be? But it's just not how we're structured as a society. Like, who gets credit? Who got an award for this? Who spent the most money? I mean, who got a pat on the back? It's the way we are structured and incentivized. I know there's a lot of doom and gloom here, but that's what we're up against, and now it's about to get worse, I think, with a lot of the assaults on the social safety net.
Why do you say that?
I say that because it's already hard to be poor and not earn a living wage, and now it's going to be harder. Like, take, for instance, the work requirements. So I never bought into this argument, like, purely saying, oh, they're taking Medicaid away, and that looks like work requirements. Work requirements does not say you're taking Medicaid away. What they're doing, like, it's a sleight of hand. They are making it all but impossible for some people to meet these administrative requirements. We saw this already during the pandemic, or the redetermination, Medicaid redetermination. Millions of people fell off because they either didn't know, or they didn't have the personal infrastructure or ability to to re-enroll, get the paperwork done. And then on the state and plan side, they didn't necessarily have the infrastructure or the processes ready to, like, efficiently keep people enrolled in Medicaid, right? So it's just, life is already tough enough when you're trying to make ends meet. And this is just a barrier that's being thrown at you, that will create even more chaos by causing you to lose your health insurance. It might be temporary, but still, what if that happens at the most inopportune time when you need your health insurance? So that's what I mean.
So, with this current reality in the state of things, is there one underrated skill that you think that everyone in healthcare should jump on immediately?
Well, that's a softball pitch over the plate for me. Speak in plain language so people know what you're saying. Let there be no confusion about what you're trying to communicate. But I think
Clarity.
the problem is there are many people who think they're speaking clearly and plainly, and they don't realize what they've said just went over someone's head, or the person has no idea what they've just been told. And that's
Clear
not just for
over.
doctors. I think it's for everybody working in healthcare. Needs to speak in the language people understand so that there's transparency and it builds trust.
Well, Thank you for reminding us that trust isn't just a value, it's strategy, it's essential. And I know our audience will be thinking differently about patient engagement after this. And of course, thank you for your time and your leadership.
Thank you for having me on here. I forgot to mention trust is measurable. We just have to
Oh,
decide we're going to measure it. Because a lot of people say, oh, trust, it's so squishy. Like, what do you do with that? Medication non-adherence, emergency room visits when you have a PCP, clinic no-show rates. These are all measures of trust.
I
So
love it.
if we decide we want to measure it, we will.
Absolutely. I think that's a really strong ending point. I love to leave our audience with tactical advice. Thanks again.
Okay. Thank you, Christina.
Bye.
Bye.